Good evening and warm welcome everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for our panel discussion on personalized medicine and bladder cancer. Voice of Healthcare, along with a supporting partner Pfizer, has taken an initiative to bring together the experts and speakers to recognize Bladder Cancer Awareness Month. Bladder cancer is a significant healthcare challenge affecting millions of people worldwide. Traditional treatment approaches have often followed a one size fits all model, but recent developments in personalized medicine have sparked new hope for more effective and tailored treatments. Personalized medicine emphasizes the recognition that each patient journey with bladder cancer is unique. During this panel discussion, esteemed experts will shed light on the latest research, cutting edge technology, and breakthroughs in personalized medicine for bladder cancer. Moreover, we will discuss the challenges and opportunities that arise with implementing medicine approaches in bladder cancer care. We aim to address the implications for clinical practice, the integration of multidisciplinary expertise, and the importance of collaborative efforts among researchers, clinicians, and patients in this existing frontier. So, without further ado, let's get started with the introduction of our esteemed panelists today. I welcome Dr. Sandeep Goyle, Head Medical Oncology, Kokilaben Dhirubhai Ambani Hospital, Mumbai. Welcome, Dr. Goyle.
Good evening.
Dr. Prashant Kumar, Chief Scientific Officer, Karkinos Healthcare. Welcome, Dr. Kumar.
Hi, good evening, everyone.
Dr. Niti Raizada, Senior Director, Medical Oncology and Hemato Oncology, Fortis Group of Hospitals, Bangalore. She will join us in a bit. So, starting with this discussion, so Dr. Prashant, sir, I would like to ask you, sir, what are the leading risk factors that are associated with development of bladder cancer?
First of all, thanks for organizing this event. And I think this is a week, as I understood, it's a bladder cancer awareness week. And I would say that this is on timely and a very appropriate topic you have raised. When we talk about any of the cancer and our perspective of the cancer was a old age disease. And I would say bladder and prostate, these are the two unique examples which we consider still that most of the time it is old age diseased. And if you see the median life or median age for developing bladder cancer, it's 72 years. But I would say last 5 years or last 8 years, it changed completely. And you'd see multiple examples where young aged person presenting with the invasive bladder cancer. Now, if you see what could be the different factors which actually induce bladder cancer, the top would come is about the smoking. And smokers are not only for the bladder cancer. Smoking contributes almost 14 to 17 different kind of cancer. But the bladder has been very clearly indicated. The smoking induced the bladder cancer. Another very good example that the male to female ratio in bladder cancer. So male to female ratio of having the bladder cancer is now 4:1. So if you are a male, for you to get bladder cancer is much higher compared to female. And it is something just opposite to the gallbladder cancer when we talk, where the females are on higher risk compared to the male. So other than that, the chronic infections are known to, and chronic infection, especially with the cystosoma infection, but not with the transitional carcinoma I'm talking. So, but any inflammation in the bladder or the chronic infection also leads patient for high risk of the bladder cancer. The workplace exposure, this is something very important for people to understand, that when you use dyes, different kind of dyes, and especially people in the dye industry, they are very much exposed to different kind of dyes, and this would actually induce different chemicals present in the dye, which could be amines, benzene, aniline. These are the top chemicals which are present in the dye, and that also leads exposure of such chemicals to the bladder cancer. Diabetes is another one example. When the people are diabetic, they are more on the risk of getting bladder cancer. A very good example is, the diabetic patient has been treated with the drug called pioglitazone. And what has been shown recently, the data, and it has been published, that the longer exposure to the drug called pioglitazone again exposed you for getting the bladder cancer. The chances of you getting bladder cancer is higher. So then another risk factor is arsenic in the water, and there are again data from some part of India where the arsenic present in the water again exposes person to get the bladder cancer in higher rates. So there are multiple cases, multiple examples where bladder cancer could be higher when it has to be exposed with multiple things. But I would still put that the smoking is something, and my request to everybody that stop smoking right away, because it is not only bringing you to the exposure to the cancer, only bladder, but many other cancer types also. Thank you.
Rightly mentioned, Dr. Kumar, that the gist of what you have said is that smoking is the main, risk factor for developing bladder cancer. Apart from that, chronic infections, pioglitazone from the diabetic patient that they take. Apart from that, certain occupations have more hazards of developing. Bladder cancer, just as the dyes that you have mentioned, and arsenic as well. So we talk about the risk factors that leads to the development of bladder cancer. Moving on to that, Dr. Raizada, I would like to ask you the current prevalence of bladder cancer in India.
So, Ridhima, like all other cancers, the data in our country sometimes is not very, I would say that there's some inaccuracies and some gaps in data. But Dr. Prashant rightly elucidated what are the risk factors. And based on that, if you just look at the global outlook, it comes as the 10th most common globally. But when we talk about India, it is ranked as the 17th common cancer. And at one point in time, that is the prevalence of bladder cancer, there are about 50,000 cases present in India at one point in time. Every year, almost 22,000 patients are diagnosed with bladder cancer, and out of which, unfortunately, half of them die because of bladder cancer. So that is the unfortunate number we have. And yes, there are some geographical distributions also related to schistosoma or some exposure to chemicals, especially work-related chemicals, sometimes even environment-related chemicals. And those, besides that, the aggregate number is about 50,000 prevalent cases of bladder cancer. Now, this includes all the three types of bladder cancer, which could be localized or non-metastatic bladder cancer. It could be metastatic bladder cancer. And when we talk about localized, it is superficial bladder cancer or muscle invasive bladder cancer. That is non-muscle invasive and muscle invasive bladder cancer.
Right. Thank you so much, Dr. Raizada. And Dr. Kumar has also mentioned that there is more prevalence of bladder cancer in males as compared to females, which is opposite for gallbladder cancer. So, can you tell the reason of this distribution among the male and females?
Whom did you ask, Ritika? Did you ask me?
Yes, Dr. Raizada. Yes.
Okay. So actually, sometimes you know what, we really don't know what are the factors which determine the sex distribution or gender distribution. And there are quite a few cancers which are surprisingly more prevalent in the men, and all the genitourinary cancer, including the kidney cancer, ureter cancer, and of course bladder cancer, happen in men more common than women. Prostate cancer obviously happen only in men, and testicular cancer, but there is quite a few cancers which are more prevalent in men. And of course, one important reason could be the environmental factors, including smoking, and of course occupational exposure to certain chemicals. These are some logical conclusions which we can draw, but there are quite a few other factors which we really are not sure about. And one other factor which I wanted to add to Dr. Prashant's list was Lynch syndrome. So this also contributes to the genetic risk factor of bladder cancer. And if you have a personal history of family history of colon cancer or endometrial cancer, these patients also have a slightly higher risk of bladder cancer as well.
Thank you so much, Dr. Raizada, for answering that question. We have discussed about the risk factors and prevalence and distribution of bladder cancer in India. Moving on to the signs and symptoms, Dr. Goyle. Sir, what are the signs and symptoms to look for bladder cancer, and how can these be avoided?
So the symptoms and signs will depend on either if the cancer is local, like in the bladder only, or if the cancer has already spread to the other parts of the body. Usually, and most commonly, the symptom is blood in the urine, and that's how the person is alerted to the problem. So when they pass urine, they find there's traces of blood or blood in the urine, then they report to the doctor. That's the most common symptom. The other symptoms are sometimes pain while passing urine or increased frequency of urination. These are other low back pain or pain, in the area of the bladder. These are other symptoms of the localized disease. And I said, commonest symptom is bleeding in the urine. So any bleeding in the urine, the message should be, please don't ignore it. Please go and see your doctor immediately if you find any traces of blood in the urine. That's the first symptom. If the cancer has already spread to other parts of the body, then depending on where it has spread, the symptoms will arise. So, for example, the cancer has spread to the bones, and you get bone pains. Then you diagnose accordingly. So you have bone pains. If it's gone to the liver, you can come with jaundice or liver enzymes to be deranged. So depending on the area where it has spread to. But again, saying most common symptom is blood in the urine, which we call hematuria.
Right. So, thank you so much, Dr. Goyle, for mentioning the signs and symptoms to look for in bladder cancer. And one of the major is hematuria, but these are not the signs that we see early in a patient of bladder cancer. In the late stages, we see these type of signs and
So
symptoms.
not necessary. Hematuria can be an early sign also, because it's a tumor is in the bladder. It starts
Right.
bleeding, and so you can get it diagnosed at an earlier stage as well.
Okay. Thank you so much, sir. Moving on to the diagnosis, Dr. Raizada. Ma'am, what are the key tests for the diagnosis of bladder cancer? And as you mentioned, Litt's disease as one of the risk factors for it. So, does genetic testing play any role in early diagnosis of these bladder cancers?
First part is that when we start testing. So as Dr. Sandeep very nicely alluded that once you have hematuria or any suspicion of chronic dysuria which is persistent, you would want to investigate a patient like that. And normally you would ask just for a routine test like urine routine, and we'll see what are the type of cells in that. If you have a suspicion of malignancy, we may ask for urine cytology. Cytology is looking whether they are malignant cells or not, or what are the type of, whether they're chronic inflammatory cells. Sometimes we do centrifuge and see whether they are, again, concentrated cells in which there's any suspicion. Imaging is recommended, and simplest imaging which we do very commonly is an ultrasound. An ultrasound of the kidney, ureter, bladder, known as the ultrasound KUB, is recommended. For specialized tests, we have to check whether what are the renal functions. So based on the renal functions, we may ask for a CT urography or an MRI urography. This could be with or without contrast based on the GFR or the glomerular filtration rate. Based on the GFR studies, if the kidney functions are good, we may want to use contrast or not. If there's a suspicious lesion, we want to do cystoscopy, in which we put like a tube in the bladder, check whether there's a bladder tumor, and any suspicious area is biopsied. So biopsy per se is the final diagnostic method of finding out what is the diagnosis, whether it is malignant or not, or it's just a cystitis. And when we find out it's malignant, then we have to find out whether it is non-muscle invasive or muscle invasive bladder cancer. And then once we have confirmed that this is malignant, then we have to find out the stage as well. So we do a good pelvic assessment by doing an MRI of the pelvis. For other sites of disease, we can do either a CT chest or a CT upper abdomen Sometimes you would want to do a whole body PET scan, but PET scan sometimes does not delineate the upper urinary tract very well. So everything else, minor the upper urinary tract, can be also assessed by a PET scan. This is the sequence of testing I would recommend, and most of us recommend. Your next question was whether there is a role of doing genetic testing. So it's a very tricky question because for early bladder cancer, there are no general tests recommended. Although people talk a lot about or doing blood test or saliva test to find out whether you are at risk of having a bladder cancer or any cancer. But these are not really the standard at this juncture for bladder cancer. There's some very small data which says that FGFR3, if it is positive, whether it is in tissue or whether it is in blood, then you may have a risk of bladder cancer. Then Lynch syndrome, again, I said that if you have a personal history and a genetic association, that could also indicate that you need screening for bladder cancer as well. Genetic test, however, is quite strongly recommended when you're already diagnosed and when you're looking for treatment options.
Right. Thank you so much, Dr. Raizada, for elaborating all the type of diagnostic tests that can be done to detect the bladder cancer early. And you talked about the genetic testing, the Lynch syndrome. So, does genetic testing is genetic testing recommended in so that we can diagnose the bladder cancer early, or it doesn't have as much as role as discussed previously? So, what is your
No,
take on that, Dr.
at this juncture, genetic testing is not a routine screening recommendation or routine. There are no genetic prescribed tests for finding out whether you are at risk of developing bladder cancer.
Okay, thank you so much, Dr. Raizada. Moving on to the treatment part of it, Dr. Goyle. So, what are the current treatment options that are available for bladder cancer?
So the treatment options will depend on the stage of the disease, whether it's early disease or advanced disease, and also what options we have. Options we have got either surgery or radiotherapy or some kind of systemic therapy, which includes chemotherapy, immunotherapy, etc. So, depending on the stage of the disease, we decide. If it's an early stage, like a stage one, then depending on whether it's what on the biopsy, we will come to know whether it what is the grade of the tumor, whether it's muscle invasive or non-muscle invasive. So, a simple resection of the tumor, like transurethral bladder tumor resection, which is called TURBT, right? So they do a cystoscopy and they see the tumor and they resect the tumor. So that is for a low grade stage one tumor, that is more than sufficient. And then depending on what the tumor comes out, what biopsy is done, depending on that, either you can just observe or you can sometimes give intravesical chemotherapy. Like in the bladder, you can do a cystoscopy and give a chemotherapy drug into the bladder to kill the cells which have been remaining after the excision has been done. And that is sometimes more than sufficient. And after that, you can follow up the patient at regular intervals by doing cystoscopy and urine testing and keep a watch. If it's a high risk early stage bladder cancer, TURBT, if you find the biopsy is high risk, then sometimes we do a bladder removal, which is called a cystectomy. Now, coming on to the advanced, slightly more aggressive stage, like stage 2, stage 3, stage 4. If it's stage 2 or stage 3, normally we do a combination of treatments. So, what we do, the standard of care is to give chemotherapy first to shrink the tumor, followed by surgery. And after that, depending on what comes out, how much comes out, and what is the aggressiveness, sometimes we may use immunotherapy as an add-on therapy after surgery as well. Sometimes if the bladder tumor has come out but the margins are still positive, then we may still consider giving some radiation as well. So it's a multimodality treatment comprising of surgery, chemotherapy, radiotherapy, immunotherapy, and it is a team approach. So no single doctor can decide and say, okay, I'm going to give this or that. It's a team approach. MDT board sits, they discuss the pathology findings, the CT scan, MRI findings, and then decide what treatment options to be given, what is the sequence of options to be treated. But mostly it is chemo upfront, followed by surgery, plus minus radiation or immunotherapy. If the disease is stage 4, advanced disease, metastatic disease, where the options of cure are not there. In those cases, we give systemic therapy. The systemic therapy, again, as I mentioned earlier, is either chemotherapy or immunotherapy. Preferable to give chemotherapy, and followed by maintenance immunotherapy. Maintenance means to keep on giving it for a longer period of time to keep the disease under control, because you cannot cure the disease in stage 4. So to keep it under control, we give some kind of therapy over a prolonged period, which the patient can tolerate also, and it helps the patient also, which we call maintenance therapy. So it's chemotherapy followed by maintenance immunotherapy. On the other hand, if the person, because bladder tumors mostly occur in the elderly, the kidney function may not be that great. So if the patient is not fit for chemotherapy, then you can straight away give the patient immunotherapy, as a initial treatment and as maintenance therapy also. So that, depending on the stage, depending on the grade of the tumor, depending on the patient fitness, the comorbid conditions, whether the patient got diabetes, hypertension, heart problems, what is the creatinine kidney level, creatinine level, depending on all these factors, you decide what options of treatment can be given to that particular patient.
Thank you so much, Dr. Goyle, for elaborating all the treatment options that are currently available for bladder cancer treatment, including radiotherapy, surgical, and chemotherapy and immunotherapy. So, continuing on the treatment part, Dr. Kumar, I would like to ask you, sir, what is the role of precision medicine and targeted therapies in the treatment of bladder cancer? And what are the key biomarkers or genetic alteration that can be targeted? And how they influence the treatment decisions.
That's a very interesting area, I would say. And I do remember when I started working on the bladder cancer, and I feel I'm blessed to work with a person who has discovered the FGFR3 mutation in bladder cancer, Professor John Paul Thierry, the French scientist. And this is where my bladder cancer journey started. And we had discovered the biomarker, which we got US patent also and Singapore patent. And those biomarker for early detection of bladder cancer, now you'll get over the counter. But coming to the question, which is very interesting, till the year 2018, we were struggling to identify a targeted biomarker or targeted therapy for bladder cancer. And I do remember that every talk we always mention that uh, last 30 years of effort, we couldn't find better than cisplatin-based chemotherapy in bladder cancer. And the cisplatin started 1965, the discovery of cisplatin in US, and 1978, FDA approved cisplatin for the bladder cancer treatment. So you can imagine from 65 to 78. And until that, there are multiple drugs have been used, gemcitabine, docetaxel, paclitaxel. But what made a bigger revolution, I would say, in terms of targeted therapy is in the year 2019, when iridafitinib, and I'm not very good with the names of the drug, but the iridafitinib was the first targeted therapy in bladder cancer, which was actually FDA approved. And that changed the perspective. And when we talk about the bladder cancer, majorly clinico-pathologically, it's divided into the two different subtypes, non-muscle invasive and muscle invasive. Now, when you see non-muscle invasive, the FGFR3 mutational frequency is higher. P53 is the one which is higher in case of muscle invasive bladder cancer. And TCGA has put amazing effort. It's a year 2014 Nature paper got published, where they have done the genome, whole genome. It was not whole genome, it's a whole exome sequencing they have done, and they have shown the tumor landscape of the bladder cancer in 133 patients. But they only congregated the studies from the muscle invasive bladder cancer. Again, 2017, the TCGA put another effort, and there the number of samples increased from 133 to 400. So it was the studies which actually identified many such mutations, and starting from P53, FGFR3, PIK3, HER2. So all these different targets we identified in case of bladder cancer. There are different drugs which have been approved. So dovitinib has been approved for HER2. Trastuzumab has been given. And again, PIK3CA is another good example where the drugs are approved, but they have some minimal, I would say, impact. And EGFR, again, neoadjuvant drug erlotinib is used. which has again showed a promise impact on the small cohort of the patient in muscle invasive bladder cancer. So I would say that it really make a very big impact in terms of personalized therapy. And these are what I'm talking is the alterations at the level of genome. We identify these are the alterations which were present in the patient and high frequency. And based on that, we take the call that these are the driver mutations. But other than that, the TMB also makes sense in bladder cancer. And you may be surprised to know, and many of the listener, that the bladder cancer actually ranked third in terms of TMB, just after melanoma and lung cancer. So you can imagine the tumor mutation burden in bladder cancer, and that also indicate very clearly that it could also stratify for us to target with the immunotherapy, because the TMB is very high. And I remember the Genentech has done a very big clinical trial which was failed in the initially, but now immunotherapy is used for bladder cancer. It's the second line of therapy. You give nivolumab, and it makes a very big impact. So I would say that TMB, MSI also, which is associated with excellent response to immunotherapy in muscle invasive bladder cancer. And these are some of those alterations we identified in terms of precision oncology and precision medicine, which directly correlated with the identification of the mutations in bladder cancer, both non-muscle invasive and muscle invasive bladder cancer.
Thank you so much, Dr. Kumar. You have highlighted, first of all, I would like to congratulate you on your achievement. And apart from that, you have highlighted different mutations that are linked to bladder cancer in the targeted therapy. How do these mutations and the targeted therapy influence the treatment decisions? That was the second part of my question.
So see, any such therapy, as I mentioned you 30 years back, we have always limited with the chemotherapy. And when we talk about the chemotherapy, we also realize that it could have a cytotoxic effect. Now, when you personalized, it means you go and check the genomic makeup. You try to identify the genomic alterations in the patient. And suppose you find a patient where the FGFR3 mutation is higher. There's a drug for FGFR3 mutation. There's a drug for PIK3. So there is a drug for EGFR. So this would impact actually the treatment regimen given for the patient, which could be personalized treatment. And we always give a very good example that it's a large cohort of patient. If you are giving a cytotoxic drug, you may not knowing that which of the patient will respond to the drug. The moment we understand that different cohort of the patient from the pool of patient, it could work on the targeted therapy A versus targeted therapy B, or the third regimen where the targeted therapy A plus B could be effective for the patient. And this is a huge impact, I would say, when we talk about the personalized therapy. And I would also add that liquid biopsy is something which I have been working extensively. The impact of ctDNA. Now, if you would target, the precision medicine is so powerful that you can actually collect the blood sample on a longitudinal time point. And if the tumor evolved, you could identify the mutations when the patient has been given therapy, post therapy. And those could be targeted again doing the whole genome sequencing or the targeted sequencing or whole exome or a small panel of the gene. Based on those identification of alterations, you could target the patient based on the therapy existing.
Thank you so much, Dr. Kumar. You have highlighted the need for precision medicine in bladder cancer and how it affects the outcome of the disease. Building on to that, Dr. Raizada, ma'am, what are the potential long-term benefits of personalized medicine in bladder cancer, both for patient and the healthcare system as a whole? And how might it impact the overall management and prognosis of the disease?
So actually, everything has been already said, but I can tell you that this is a concept which all of us use right from diagnosis, which is called as personalized diagnosis. I mean, you know when it is a non-muscle invasive, what needs to be done, and muscle invasive and metastatic, and so on. When there's a family history, how you tailor make treatment. When you know the patient is cisplatin eligible or ineligible, how you tailor make the treatment. So it starts from personalized diagnosis to personalized therapy with all the ingredients where Dr. Prashant mentioned. And then, yes, where we can use chemoradiation upfront, where we only have to use a neoadjuvant chemotherapy upfront and follow it with partial cystectomy or radical cystectomy. And then where do we have to use adjuvant therapies, and what kind of adjuvant therapies are used, what maintenance are used? Well, those are all a part of personalized care or personalized medicine, or I mean customized treatment for that individual. Whether they express immunotherapy biomarkers like tumor mutation burden, MSI, whether they express PDL1, where we can use immunotherapies, and when they are platinum ineligible and these things are there, then what drugs can be used? These are all customized or personalized treatment. Then there's a tailor made follow up. A patient who's at high risk of recurrence will require tailor made follow up. They'll require closer follow ups. They'll require probably check cystoscopies for an early or superficial or non-muscle invasive bladder cancer by during the time of giving weekly therapies, followed by a check cystoscopy, then monthly maintenance intravesicular therapy, followed by check cystoscopy. And for muscle invasive, it will require a different follow-up, and for metastatic, it may require a different follow-up. Then that is one. Then when you actually do tailor-made treatment, it comes at reduced healthcare cost, because it is a tailor-made individualized treatment which actually cuts the whole financial burden on the patient and the healthcare system. So we know which patient has to be followed up closely, and which patients can be telephonically followed up, or which patients can be followed by infrequent uh, coming to the hospital. So basically, all these personalized treatment will increase patient satisfaction.
Rightly said, Dr. Raizada. And also, you have mentioned regarding the patient satisfaction. Apart from that, what are its benefits to the healthcare system as a whole?
See, all of us as doctors primarily care about results, and we definitely want to achieve the best results for every individual, for every patient. So, by doing a personalized care, we are achieving maximum output by getting maximum progression free survival, or probably achieving maximum overall survival. And that's what we achieve as doctors, as a healthcare team. And when you actually focus on one subspecialty and you intensely do things with maximized results, that's actually good quality of healthcare delivered to the patient.
Yes, Dr. Raizada, you have rightly mentioned that it enhances the quality of life of the patient as a whole, and the quality of care to the patient. And we have discussed about the benefits of personalized medicine. I would like to ask Dr. Goyle, so what are the current challenges and limitations that are there in implementing personalized medicine bladder cancer care? And how can these challenges be overcome to ensure broader accessibility and option of these approaches?
I think as oncologists, we are now into the era of person medicine. There's no doubt about it. But saying that, I think the person medicine also differs from tumor to tumor. Now, if you take the example of, unlike cancers like lung cancer, breast cancer, colon cancer, where person medicine is a different, level as well. Bladder cancer, I personally feel has still not reached that level. Dr. Prashant has mentioned about the various mutations or genomic alterations which occur. But saying that, it is the main limitation which we find is that the frequency of these mutations or alterations in bladder cancer is very low. I think that's the biggest limitation. So many patients, we find that these alterations are not seen in these patients, and therefore we are not able to use the drugs which can be used in bladder cancer for these particular alterations. So that's the first thing, that the frequency of the alteration of mutations is very low in bladder cancer. That's the first thing. Secondly, even if you identify a mutation, usually the medicines are not available. They are not available in India. Erdafitinib is not available in India, right? So you have to get it from US, and it's just expensive medicine. The patient, even if you are able to get it, the patient not able to afford the medicine. So very few patients are able to afford these medicines. So the accessibility, the availability of these medicines, first of all, the cost of the test, you do a person's test. These tests are expensive tests, so you cannot generalize these tests for all the patients. So first of all, the test cost. Secondly, the frequency of mutations alterations is low. Thirdly, if you can find a mutation, then the drug is either unavailable in India, or to get it from abroad is too expensive. So all these are the challenges and limitations of implementing personalized medicine in bladder cancers, right? And how can you overcome this? So again, Research, that's the most important thing. We doing ongoing research is there. The moment we find more alterations, we are getting more new drugs, and generic medicines are coming in, so hopefully the drug cost will become cheaper. And more importantly is the mindset of the doctors. The doctors have to now start thinking that yes, we have to find a target. We have to find an alteration, genomic alteration, which we can target, and use this personalized medicine space in bladder cancer as well. So I think the mindset has to change. The government policies have to change. We need more luck to find more alterations. We need pharma companies to reduce the drug cost. So I think it's still a long way to go in bladder cancer personal medicine. Unlike lung cancer, breast cancer, colon cancer, where we are quite ahead. That's what I feel.
Thank you so much, Dr. Goyle. You have mentioned regarding the accessibility and affordability of medicines. Even if we do the personalized testing, also there is no accessibility of the medication that is to be there to treat those in the targeted therapy area. And you have mentioned about the research part as well. So moving on to the research part, Dr. Kumar, sir, what is the role of clinical trials in advancing personalized medicine in bladder cancer, and how can patient participate in clinical trials and contribute to the development of new personalized treatment approaches?
So I think Dr. Sandeep has mentioned very rightly, and I completely agree what he mentioned, that no matter what we talk about the alterations, but it has to be translatable. So you can translate, because many of the time we are limited with the drug accessibility, what he mentioned very correctly. See, now if you see the clinical trials, and you may not believe that if you put NIH Gov and clinical Gov, you'll find more than 1600 clinical trials on bladder cancer. And I do remember the year 2015 when I was putting it, and the number of clinical trials, it was 800, 850. And now see that it's double. And if you go and dig it more, you identify that everything has been tried for bladder cancer. It's starting from teas, starting from coffee plants, bark. So people are trying every different aspect of trials to identify something which work for the bladder cancer. And definitely it is needed. What is needed is that we need to do more and more NGS. The mindset need to change. We are still talking about the data from the Caucasian population, and I'm talking about the numbers 133 TCGA. Just imagine the sequencing data is coming from 100, 200, 300, 400 max. And we need to do sequencing more than thousands to identify. When we talk about the frequency of mutation, we can only conclude that okay, these mutations are prevalent until unless we will do in a larger cohort of the patient, and especially for Indian centric patient, to identify some of those exclusive mutation in non-muscle invasive or muscle invasive bladder cancer. So that will be definitely the participation from the patients, that and again the clinician mindset that okay, let's do the NGS, and NGS should be practiced in the bladder cancer compared to other cancer. When we Dr. Sandeep was talking about the lung cancer is a beautiful example. So we need to really improve. We really need to change the mindset that it has to be sequenced. We would identify which of the mutations are prevalent, and those mutations could be targeted. Now, to run such kind of clinical trial, what is needed is the multi-centric research clinical trials, and we need to initiate such clinical trial in India. It could be only happen with the large collaboration, the collaboration from multiple urologists, multiple research centers to collaborate on such kind of clinical trial. And I'm not talking about the phase 3, phase 2, 4. I'm talking about the phase 1 clinical trial, that India should take the lead. This is the time that we need to really identify the areas. We need to identify those places where we should take the lead, and especially for the Indian centric patient. So it could only happen when multiple institution comes together, multiple center. It could be Tata Medical Hospital, it could be any other private institution where the clinician can take the lead, and we could work on bigger clinical trial where the clinician took the lead, and clinician should take the lead to identify the Indian centric patients response to the drug, and that will actually change the face of the many of those medicine when we talk about the personalized therapy in Indian cohort.
Thank you so much, Dr. Kumar. I think you have rightly mentioned that we are still looking through the Caucasian population and the researches that are done in that population. We need to focus on Indian population as well with respect to the targeted and personalized approach. Dr. Goyle, would you like to add something to what Dr. Kumar has said?
No, I think we have covered most of the points we have and uh, I feel personally it's just mindset has to change. Few years ago in lung cancer also we were not doing all these tests, but now for all lung cancer patients we do the NGS. The same way we have to do it for other tumor types as well, including bladder cancer. And it has to be a effort from all the sides, the government, the politicians, the doctors, pharma companies, then only, the drugs will be made available to the common patient. Otherwise just identifying a target and saying, okay, we can give this, but you're not able to deliver the medicine, there's no point. It's just a waste of money for the doing a test as well. At the end of the day, it has to translate into clinical practice.
Right, Dr. Goyle and Dr. Kumar. I think both of you have rightly mentioned that we need to have a multidisciplinary approach for the targeted therapies or any kind of treatment for bladder cancer in India. So we have two, three questions from the audience as well. So I'll highlight those on the screen. And the first question is. What are effectivity or response on personalized medicine, and how to define the pool of patient who could be targeted? So I think this question might be relevant with Dr. Kumar. So would you like to answer the question?
So, see, the first part is what are the effectively or response on the personalized medicine. There are multiple set of data already exist where FGFR driven or HER2 driven targeted therapy has been given, and partial response sometime, and then sometimes good response. I don't tell that it's the extraordinary response we are getting, and more data need to be generated. Second part of the question is how to define the pool of patient who could be targeted. The only way is that you do NGS. Once you do NGS, you will identify the pool of the patient. And I'll again give you a very good example. Lung cancer, now we know some of those mutation about the exons 18, 19, 21, 22, smokers versus non-smoker. We find exclusive mutations. Now we know that exclusive mutation between male and female, smoker and non-smoker. Similar kind of signature we may identify in case of bladder cancer also, and then we will be more conclusively we can tell that okay, this particular mutation, this particular exon mutation is happening in smokers or in female or in male, and I think that could be achieved doing more NGS.
Right. Thank you so much, Dr. Kumar. And moving on to Dr. Goyle, sir, there is one question for you as well. Is there targeted therapy based on mutation of bladder cancer in regular clinical practice?
Well, as already mentioned, if you find a mutation or genomic alteration, although maybe it's less frequency, like example HER2, if you find, which I think is hardly seen, but if you like FGFR mutation has already been alluded to now, but again, in clinical practice, we don't have the medicine. So even if you find the mutation, we are not able to get that medicine to the patient. So right now, that's the limitation of target therapy in bladder cancer. In very rare cases, we find some mutation which we already have medicines and we use it for other cancers, then obviously we can use those medicines. But as I said again and again, the chance of finding that mutation is very low, and hence the usage of the medicine target therapy is low.
Uh,
Immunotherapy we are using more commonly in bladder cancer. We have a marker called PDL1. The PDL1 is high, then immunotherapy can be used as single agent as well in place of chemotherapy in patients who are not eligible for chemotherapy. So PDL1 is a biomarker which can be used for bladder cancer as well as in lung cancer and other cancers as well.
Right. So building on to that, we have another question on the same front. So, are we only considering personalized medicine only based on mutation, or there are opportunities of methylome, proteome, or metabolomics in future? So, I think Dr. Kumar would like to answer this.
Yeah, so Dr. Gaurav, it's a very, very valid question what you have raised. Are we considering personalized medicine only based on mutation? I would say personalized, the term, it's not only mutation. I was mentioning that it is TMB also. TMB also giving us a very clear idea about the patient, and the information about the patient could be given the immunotherapy. It is MSI also. So there are multiple aspects of the personalized therapy. ctDNA is another very good example. If you take the plasma and if you see the ctDNA load is high, you just do sequencing and identify those mutation also in the longitudinal arm. So many such information, it is over the time we get collected, and then the signature gets generated. EGFR for erlotinib in lung cancer, not one day job. It has been actually seen multiple patient, and now gefitinib, erlotinib has been given, or osimertinib. So once we will generate multiple set of data, the pharma company will definitely come forward, because they will understand the importance of just such mutations, and again the price point, that everything will be sooner or lesser. They will realize that okay, these are the mutation which is prevalent, and we need to come forward to identify the drug. We need to also see how can we minimize the drug, because pharma tomorrow they want these drugs to be given by the patient, or given by the clinician to the patient. So everything starts, it's like you need to initiate the journey, and things will add. The second part of the question, what was the, can you just revisit the question?
Sure, sure, sure.
Yeah.
So, are there any opportunities?
Yeah.
Yeah.
Got it. So see, we always keep telling that the multi-omics is the future. When we talk about the genomics, and why the genomics is much more known in cancer, because cancer is a genetic disease. And when we talk about the genetics, it start with the alteration at the level of genome. And genome is something where you can actually identify the mutation. But of course, the future is methylome, proteome, phosphoproteomics, I would say, because most of the targeted therapy you see, either BCR, ABL, gefitinib, and all this is actually targeting the kinase. And these kinase, and we need to identify multiple kinase doing the proteomics and phosphoproteomics, because these kinases are active, and once these kinases are active, it actually activate host signaling pathway. It is either EGFR, TGF beta, TNF alpha, so all these pathways. So we must need to identify, and that's the only way, that when we go and do the multi-omics approach, where we could dissect the disease at multiple level, starting from DNA, RNA, and protein, and metabolomics too.
Thank you so much, Dr. Kumar, for elaborating that for our audience. And before concluding the session, I would like to, ask any concluded remarks for both of the panelists. Dr. Goyle, would you like to say something before I conclude the session?
I think oncology right now is a very interesting field. We are going through a lot of changes in the treatment paradigms for different cancers. We have made huge developments in certain cancers like lung cancer, breast cancer, colon cancer, and I think other cancers are not far behind. I think over a period of time, we will get there. And there's a lot of hope for our patients, which was not there earlier. And it's all the combined effort of researchers, clinicians, different modalities of treatment. And I think we're looking at a great future ahead in the field of medical oncology and in precision oncology, especially precision oncology.
Dr. Kumar?
Yeah, I do agree with Dr. Sandeep that that we need to be very optimistic, and that is the thing we have to actually inculcate the idea of optimism, and that could be only achieved by collaboration, and collaboration from the researcher, clinician, pharma company, and I think we are learning every day. And there's no, in science I always tell that there's no black and white, there's always a gray area. We can debate for hours, and just to say that okay, I am correct, or my thought is correct, but I would say that we need to come in a very you know uh, conclusive way, and a very concordant way, that how it could be we can translate from bench to bed, and that is the bigger task. And I think more research has to be done, more participation from the patient and clinician and researchers, so that we could identify a way to take things forward. And I foresee a very great future for the precision oncology in cancer.
Thank you so much, Dr. Kumar. So, with this, I would like to conclude this session here. And I would like to thank both Dr. Kumar, Dr. Raizada, Dr. Goyle for taking time for this critical panel discussion today. This discussion has been very informative and has provided so many valuable insight into the bladder cancer issue. So, thank you so much, Dr. Kumar, Dr. Goyle. Thank you
Thank
so much.
you. Thank you very much.
Thank you so much.
Thank you. Bye.